The do's and don'ts of toothbrushing, part 2. In the first part, we discussed about various types of toothbrush and dentifrices. Let's move ahead now. So the question arises, is there a correct way to brush teeth? The brushing techniques can be classified based on their brushing motions used, like horizontal, rotary, vibratory, and vertical. Horizontal motion, where horizontal motion is used for brushing teeth, that technique is known as scrub method. Rotary motion is used in Fones technique. Vibratory method is used in Bass method, Stillman's method, and Charter's method. And vertical motion for brushing teeth is used in rolling stroke, modified Bass method, modified Stillman's method, Leonard's method, and Smith-Pill or physiological technique. So these were the various techniques of brushing teeth. Now, which technique should I use? The most common method of brushing is scrub technique, which is mostly used by people. The most recommended one is Bass or circular method or modified Bass method. In case of gingival recession and root exposure, modified Stillman technique is advised. In healing wounds after surgery, Charter's method is advised. In children, Fones technique is recommended because it's quite easy to use. And the least effective technique is roll technique. Modified Bass method, this is the most commonly recommended technique by the dentist. Place the head of a soft brush parallel to the occlusal plane with the brush head covering 3 teeth beginning at the most distal tooth in the arch. Place the bristles at the gingival margin, establishing an angle of 45 degrees to the long axis of the teeth. Exert gentle vibratory pressure using short back and forth motions without dislodging the tips of the bristles. This forces the bristles into the sulci as well as into the interproximal embrasures and should produce perceptible blanching of the gingiva. The modification consists of sweeping the bristles downwards over the tooth surface occlusally after completing the vibratory motion in the gingival sulci. Complete 20 strokes in the same position. Lift the brush, move it anteriorly, and repeat the process for next 3 teeth. To help reach the lingual surfaces of the anterior teeth, if the brush seems too large, insert the brush vertically. Press the heel of the brush into the gingival sulci and proximal surfaces at a 45 degrees angle to the long axis of the teeth. Activate the brush with 20 short vibratory strokes. To reach occlusal surfaces, press the bristles firmly into the pits and fissures. Activate the brush into 20 short back and forth strokes, advancing section by section until all posterior teeth in all quadrants are cleaned. To reach distal surfaces of the last tooth in the arch, open the mouth wide and vibrate the tip of the brush against that surface 20 times for each tooth. The advantages of this technique is the short back and forth motion, it's easy to master. Cleaning action is concentrated on the cervical and interproximal portions of the teeth where most of the dental plaque detrimental to the gingiva is located. A disadvantage is the manual dexterity it requires. When properly done, modified Bass technique gives you a sparkling smile. Modified Stillman's technique. In this technique, the soft multi-tufted brush should be placed with the bristle ends resting partly on the cervical margin of the teeth and partly on the adjacent gingiva, pointing in an apical position directed at an oblique angle to the long axis of the teeth. So this is its difference from modified Bass. In modified Bass, the angle was 45 degrees. In modified Stillman, the angle made by the bristles is an oblique angle. In modified Bass, the toothbrush was placed in the gingival sulci and partly on the tooth, whereas in modified Stillman, the toothbrush is placed partly on the gingiva and partly on the tooth. The brush is activated with 20 short back and forth strokes and is simultaneously moved in a coronal direction along the attached gingiva, the gingival margin and tooth surface, and the process is repeated in all the teeth. This technique is basically recommended for cleaning areas with progressive gingival recession and root exposure to prevent abrasive tissue destruction. Its disadvantage is it's quite time consuming and it might damage the epithelial attachment if not properly done. Charter's method. A soft brush is placed on the tooth with bristles pointing towards the crown at a 45 degrees angle to the long axis of the teeth. The sides of the bristles are flexed against the gingiva and the back and forth vibratory motion is used to massage the gingiva. This method is effective particularly in cases with receded interdental papillae. It is suited better for gentle plaque removal and gingival massage when using soft brush, and this technique can be recommended for temporary cleaning in areas of healing wounds after periodontal surgery. It can be used in patients wearing an FPD or orthodontic appliances. Its disadvantage is poor subgingival cleaning and limited brush placement, and it requires digital dexterity. This technique is based on the concept that in case of receded papillae, the gums have been pulled down and more of the tooth has been exposed. And in patients wearing orthodontic appliances, it is important to clean the facial surfaces of the teeth. So the brush is placed in such a way so as to cover the facial or the front surfaces of the teeth. Roll technique or Fones method. It is one of the most commonly recommended technique for children because it's quite easy to learn. The filaments of the brush are placed towards the root of the tooth. The side of the brush is placed on the gingiva and the plastic part of the brush is placed evenly with the tooth. It is pressed against the gingiva and then the brush is rolled over the teeth. The wrist is turned slightly and the filaments follow the teeth contours. Its disadvantage is limited interdental and circular cleaning. Leonard's technique. The bristles are placed at 90 degrees to the facial surface of teeth. Brush vigorously without great pressure, mostly up and down strokes are used. Its advantage is it's quite easy to master because just vertical strokes are used. Its disadvantage is the inadequate interdental cleaning. It's basically recommended for small children. Scrub technique is the simplest method. It consists of merely placing the bristles next to the teeth and moving them back and forth or in a scrubbing motion. Its advantage again, it's easy to master, so that is why it is most commonly used by people. Disadvantage is poor plaque removal. It causes cervical abrasion and gingival recession. Smith's or physiological technique is based on the principle of the physiologic pathway that is followed by the food when it traverses over the tissues during mastication. Bristles are placed pointing incisally or occlusally and then moved along and over the tooth surface and gingiva. Its advantage is it follows a natural self-cleaning mechanism. Its disadvantage is interdental and sulcular areas are not adequately cleaned. Interdental cleaning aids. Interdental plaque removal is of importance because most of the pathogenic organisms originate in the interproximal areas. Toothbrush, regardless of the brushing method used, does not completely remove interdental plaque, hence the need for interdental cleaning aids. Factors determining the selection of interdental aids are the type of embrasures. Type 1 embrasure is where the interdental papilla fills up the embrasure. Dental floss is advised in these situations. Dental floss is the most commonly recommended method of removing plaque from interdental areas. The types of dental floss available are twisted or non-twisted, bonded or non-bonded, waxed or unwaxed, and thick or the floss must contact the proximal surface from line angle to line angle to clean effectively. It should also cover the entire proximal surface, not just lipped apically to the contact area. Once the floss is apical to the contact area, move it up along the tooth till the contact area and down into the sulcus again. This is repeated several times and the same is repeated on the proximal surface of other teeth. Type 2 embrasures are where there is moderate papillary recession. In these cases, miniature interdental brushes and wooden tips are recommended. Interdental brushes are cone-shaped or cylindrical brushes made of bristles mounted on a handle. Two types are available, single tufted brushes and small conical brushes, which are mainly useful to clean large, irregular concave tooth surfaces adjacent to wide interdental spaces. They are inserted interproximally and are activated with short back and forth strokes in between the teeth. They are most useful in furcation areas, isolated gingival recession, and on the lingual surfaces of mandibular molars and premolars. Wooden toothpicks, these are available either with or without a handle. An example of soft triangular wooden toothpicks is stem U dent, which is placed in the interdental space in such a way such that the base of the triangle rests on the gingiva and the sides contact the proximal surface of the tooth. It is moved in and out of the embrasure, removing the soft deposits from the teeth. Wooden toothpicks attached to a handle, an example of that is perio 8, which is used on the facial and lingual surfaces throughout the mouth. In type 3 embrasures, when there is complete loss of papilla and interdental gingiva is tightly bound to the underlying bone, as seen in the case of dystema, a unitufted brush is recommended. Chemical plaque control. Mechanical plaque removal remains to be a primary preventive method to control dental diseases, and it should not be replaced by chemical plaque control. However, chemical plaque control can be used as an adjunct to effectively control gingival inflammation and prevent the recurrence or progression of periodontal disease. The ADA Council on Dental Therapeutics has adopted a program for acceptance of plaque control agents. The agents must be evaluated in placebo-controlled clinical trials of 6 months or longer and demonstrate significantly improved gingival health compared with controls. To date, only 2 agents have been accepted by the ADA for treatment of gingivitis, which are chlorhexidine digluconate mouthwash and essential oil mouth rinse. Chlorhexidine is a second-generation antimicrobial agent. It is used as an adjunct to mechanical oral hygiene in initial periodontal therapy. During post-surgical period, immediately after plaque removal, complete plaque control can be achieved without extensive use of proximal cleaning aids, which are painful to use and may delay healing. Improves healing after routine oral surgical procedures and in the post-operative management of immediate denture construction. Patients wearing fixed orthodontic appliances or intermaxillary fixation devices will benefit from a daily rinse with a 0.2% chlorhexidine solution. Chlorhexidine will help to control plaque accumulation in patients with drug-induced gingival overgrowth. It can also be advised in patients with local oral infections such as denture-induced stomatitis, aphthous ulceration, dry socket, and acute ulcerative gingivitis. In medically compromised patients who suffer from recent gingival oral infections, and in handicapped patients whose plaque control and gingival status are often very poor. Finally, it can be used as a prophylactic rinse in the prevention of post-extraction bacteremia, dry sockets, and to reduce the bacterial content of the aerosol sprays during the ultrasonic. Disadvantages or the unwanted effects of chlorhexidine are extrinsic staining of teeth, painful desquamative lesions seen on the oral mucosa may be associated with burning sensation, impaired taste sensation, and parotid swelling, which is quite rare. It can occur due to mechanical obstruction of the parotid duct. Chlorhexidine is a second-generation antimicrobial agent. It is retained longer in the oral cavity or tissues as compared to first-generation antimicrobial agents. Slow release property provides overall reduction in plaque score by 70 to 90%. It is a bis biguanide. It has a broad spectrum of antibacterial activity. In general, gram-positive bacteria are more susceptible as compared to gram-negative bacteria. In relatively higher concentrations, chlorhexidine is bactericidal. At lower concentrations, it is bacteriostatic to susceptible bacteria. The cationic molecules of chlorhexidine bind readily to the oppositely charged cell wall and interfere with the membrane transport, initiating a leakage of low molecular weight substances. In high concentrations, chlorhexidine penetrates the cell and causes precipitation of the cytoplasm. For using chlorhexidine mouthwash. About 10 ml of chlorhexidine mouthwash is used. The commercially available products in the concentration of 0.2% are Rexidine and Hexidine Chlorhex. In 0.12% it is available as Periogard. About 10 ml of the solution is swished in the mouth for about 1 minute. 30% of the drug is retained in the mouth due to its property of substantivity, that is, the bound drug is released slowly over a period of 8 to 12 hours and is released slowly, leading to an overall reduction in plaque score by 70 to 90%. Hence, it should be used 1 to 2 times a day as it has higher substantivity. 0.12% chlorhexidine is equally effective in plaque inhibition when used as a mouth rinse, so it can be used twice daily. However, chemical plaque control cannot be used as a supplement to scaling and root planing, which is the monotherapy, and it is not so effective in controlling total plaque inhibition. Listerine is another of the ADA accepted agent for treatment of gingivitis. It is an essential oil mouth rinse. It contains thymol about 0.06%, eucalyptol 0.09%, benzoic acid 0.15%, menthol 0.04%, and acetyl salicylate. It has been reported to be effective in reducing plaque and gingival scores. It aids in cleaning the tongue. It is used in a scraping motion, available in plastic and metal. It should be used at least twice a day. It helps in controlling halitosis. Tongue cleaner is an important auxiliary cleaning aid. Be used at least twice daily or preferably after every meal. Advanced aids for additional cleaning. Rubber tip stimulator. It is used for gingival massage. It produces epithelial thickening, increased keratinization, and increased mitotic activity in the epithelium and connective tissue. Oral irrigation devices. These are of several types. One can use water faucet to irrigate between and around. Oral irrigators clean non-adherent bacteria and debris from the oral cavity. It has been shown to disrupt and detoxify subgingival plaque and can be useful in delivering antimicrobial agents into periodontal pockets, that is subgingival irrigation. Halita is used for treatment of oral malodor. Its mode of action is the conversion of volatile sulfur compounds by using various metal ions. Zinc is an ion which bonds to the twice negatively charged sulfur radicals to reduce the version of volatile sulfur compounds. Halita is a new solution containing 0.05% chlorhexidine, 0.05% cetyl pyridium chloride, and 0.14% zinc lactate with no alcohol. And finally, professional cleaning. If you like this video, please do like and subscribe. You can also hit the bell icon to be notified whenever a new video is uploaded.